just to say welcome to this afternoon's webinar where we're going to be talking about PEG tubes and PEG feeding. And just to say the point of this afternoon is really to raise issues that probably are best thought about when making the decision about whether to have a PEG tube or not to have a PEG tube. And the aim isn't to persuade people one way or the other. It's really just to raise some of the things that we need to think about. So I'm just going to introduce our panel for this afternoon. So we've got I don't know if everyone is seeing it the same as me, but in the top left we've got Kira. So Kira Mackey is a lead dietitian for adult community in Milton Keynes. And underneath her on my screen, we've got Kathy Lyon, and Kathy was formerly the owner of a care home that specialised in looking after people with Huntington's disease. And in the bottom right of my screen, we've got Jo McCabe, and Jo is formerly a specialist advisor for the Huntington's Disease Association, and now she's a Huntington's disease nurse consultant for Exemplar Healthcare. So we're really pleased that Jo and Kathy and Kira are taking the time to be with us this afternoon, and just to talk through some of the issues that it's good to think about when making decisions around PEG feeding. So the format is Jo is going to take us just through a few slides just to sort of bring to mind sort of exactly what we're talking about when we're talking about PEG tubes. And then we're going to have some questions that I'm going to put to the panel, and each of our panelists is going to take a bit of a lead in answering some of the questions, but we're all going to chip in, and hopefully we'll cover a lot of the issues that perhaps should be considered.
Yeah, so we thought we'd just talk you through a little bit about what a gastrostomy tube is first, because there may be some of you on the training that has never seen one, doesn't know what one really is. So basically, it's a little feeding tube that connects your stomach cavity straight onto your overlying skin, so that you can have food and feeds through it. Fluids can go into it, and if necessary, medicines can go directly into your tummy if it's unsafe or you're finding it really difficult to eat or drink. So there's two methods of putting a tube in. One is called a PEG and one is called a RIG. And that partly depends actually what part of the country you live in as to what is offered. So a PEG just stands for percutaneous endoscopic gastrostomy tube, and it means that it's inserted via your food pipe down into your stomach endoscopically. A RIG is just done via X-ray control, and you have to have sort of barium placed in the stomach for them to guide it through so they know they're going into the right place. With somebody with Huntington's disease, in some parts of the country, again, these tubes would be fitted via the surgical procedure with a surgeon under a general anaesthetic rather than endoscopically, due to sort of movements that people may have with Huntington's disease. So we just got a few pictures here for you of either a PEG or a RIG and what they actually look like. So the picture on the left is what it will look like before it's inserted. It has a little bolster that holds it into your stomach. And you can see on the right what it would actually look like. Generally, these are what you'd have put in the first place. And on our next slide, we've got some possibilities that might happen after that. I'm not aware of places in the country that would put these in initially, but I don't know whether Kira knows whether they put other ones in straight away. So these ones are called balloon gastrostomies. Again, I think they may put them in initially in some places. Do you know, Kira? Or is it usually a PEG or a RIG initially? But these are ones that can be used. Yeah, as replacements if necessary in the future should one come out or anything. These are held in place generally by a little balloon, but again, it depends on the make of the tube. Sometimes they've got a little soft bolster that holds them in place as well. And it looks pretty much the same on the outside of the skin as the initial ones that I showed you. And that's probably it, is it? Oh, this is just a different type. These are mini. These sit a little bit flusher to the skin. Again, these may be used as well. These are often ones that are used in babies that have got feeding difficulties as well, but they just sit a little bit flusher to the skin.
So that was just really to bring to mind exactly what we're talking about when we're talking about gastrostomies. And so I'm going to come to Kira first, and really, I suppose the first question is people might have is, so, what are the circumstances where it might be suggested to someone that perhaps a gastrostomy tube should be considered?
Thank you, John. There's various, I suppose, reasons why either you may be considering having a gastrostomy tube, or it might be suggested to you by one of your care team. I suppose the first one, possibly the most obvious one, is if swallowing becomes really difficult. So if people are kind of struggling to swallow on kind of lots of different textures, or kind of regularly at meal times, then that's often something that kind of instigates the conversation or gets people to start thinking about it. Or if you're having kind of lots of kind of choking episodes, so you're doing your best to eat and drink, but things are going down the wrong way regularly, and maybe you've started to get kind of more regular chest infections, which is a sign that maybe food or drink is going down the wrong way. All those kind of issues surrounding swallowing quite often tend to be the first thing that that will happen, that will maybe make you start thinking about having a tube, or suggesting to somebody to have a tube. It doesn't always have to be, I suppose, as maybe severe as that. Sometimes with just kind of milder swallowing difficulties, meal times can become really long. So sometimes, I mean, I don't know the average time. We eat our dinner maybe in 15 or 20 minutes, or if you're a bit of a gannet like me, you scoff it in 10 minutes. But quite often with people that have difficulties, I've seen it with some of my clients where it can be a half an hour or 3/4 of an hour that it's taken to eat meals. And again, kind of food is supposed to be a pleasure, and it's a pleasure when it takes a reasonable amount of time. And it maybe becomes, or can become, a little bit less of a pleasure if kind of, half your day is taken up trying to get sufficient food into you. So sometimes kind of really long meal times are what starts the process, or starts the conversation. Lots of people will be on things like a high calorie diet and so on, because lots of people with HD have higher calorie needs. So they'll sometimes be advised by a dietitian, for example, to have high calorie, high protein foods, to try and stop kind of any weight loss. And it could be that somebody's actually been started on supplement drinks, like things like, depending on where on the country you are, things like Ensures or 40-sip drinks, things like those. And sometimes we've maximized the amount that people can actually just physically fit into them in a day. There are so many hours in a day. And it could be that you're doing all those things, or your client is doing all those things, and they're still losing weight. And again, that often prompts the conversation. Sometimes it's not necessarily to do with food, but it's actually more to do with fluids. So kind of thinner fluids, particularly water, it tends to be the thinnest. Thinner fluids tend to be quite difficult to manage if you have a swallowing problem, or can be. And some people just struggle to get enough fluid into them over the course of the day, and kind of struggle with dehydration, and with their urine output being really dark in color and so on. So again, that might prompt conversation. And likewise with medication as well. Sometimes people struggle to swallow tablets and so on. I think it's useful possibly to say that obviously not every medication, but most medications are available in a liquid or a soluble, some kind of a soluble format. And so you may wish to consider going down that route before considering a PEG. But I suppose that the important thing to say is it affects different things, affect different people at different stages of the disease process, and it can be different for everybody. But they're the kind of usual reasons why people would start to consider.
Yeah, great. Thanks very much. And I suppose leading on from that, you sort of touched on a few things there, but what so, if someone was saying, well, what are the benefits to me of having of tube feeding? What sort of things would be thinking of?
So I suppose the benefits really are they're varied depending on the difficulties that you're experiencing. So I suppose that the main point I would like to make in this bit is that it's not one or the other. It's not start having a peg feed and therefore you have to stop eating. It can absolutely be both, and for most people it is both. So if you do have a peg placed, you can obviously use the peg to top up your nutrition and still continue to eat what you fancy or what you're able to manage orally. So they can definitely complement each other. So I wouldn't want anybody to think that you have a peg placed and then you stop eating. That's not the case at all. It can also take the pressure off you, I suppose, is one of the benefits. We talked about obviously kind of long meal times, extended meal times, and it can take the pressure off you trying to get in this, and usually much more so than the average population, this large volume of food that you need to try and get in, again, because calorie requirements are often increased. So if it's taken a very long time, you can obviously give half of your nutritional needs through the peg, 3/4. You can give nearly them all and still decide just to eat a very small amount of food. So say I have a gentleman who I can think of who has chocolate mousse for breakfast, chocolate mousse for lunch, and chocolate mousse for dinner. And all he has is a few teaspoons each time because he thoroughly enjoys it. And we give all of the rest of his nutrition, all the good stuff, through the peg tube. And so, but you do have people still who eat proper meals each day and eat reasonable amounts of them, but maybe just not quite enough for their needs. And then we can top up through the peg. So you can obviously eat small amounts of food just purely for pleasure, I suppose is the point on that. Touching on the hydration side of things, obviously, again, there are some people that I have on my books who are actually managing to continue to eat really well and continue to eat a good volume of food and maintain their weight, but actually drinking is the problem. And purely then it's just additional water through the tube. So again, you can continue to drink what you're able to manage to and what you like to drink, and we can just advise you on how much extra water that you would need to try and make sure that you top up your hydration and get a good amount of fluid into you. I have some people who have had their tube placed and just literally at the moment just take medications through their tube. So as I said, most of the medications are available in a liquid or a soluble format, that you can then directly put through the tube just with a little flush of water before and afterwards, and that pushes the medication in through the tube into your stomach so that your body can use it. So again, medications only is a benefit, and obviously medications are hopefully prescribed for you because they're useful. So knowing that you're able to get those into you without difficulty can be a very useful thing. And I suppose the last thing is there's kind of lots of myths, I think, about HD and so on, about, oh, it's impossible to gain weight and so on. And some people do have difficulty kind of maintaining or gaining weight. Sometimes even with a peg tube, it can be difficult. But with my personal experience, I think lots of people are able to put back on some weight they've lost or stop themselves losing any more weight. So trying to keep yourself kind of better nourished and so on is often something that can be a positive from a peg placement.
I don't know if Joe, Kathy, you got anything to add in terms of benefits?
Yeah, I was agreeing with Kira there that from the reasons why you're having a PEG would, in some of the patients that we had, they panicked when eating. It became when they had to eat, they could eat, but they panicked about it because they panicked about choking. Maybe they'd had one bad choke or maybe a couple of bad chokes in the past, and eating was becoming a challenge. So that having the PEG in, as Kira said, they were able to continue to eat, but that lessened the pressure for them and improved their quality of life. So food times became a big challenge prior to the PEGs, and their quality of life was quite a challenge for them at that point. And then having the PEG did make a big difference to that. And certainly I agree, being able to hydrate if someone's unwell or getting the medications in was a great bonus as well. And they do put on weight. She's quite right there too. Too much sometimes if they're doing both.
Great, thanks. That sort of leads on. So I suppose it's now to think about sort of like the other side of things. So potentially what might be some of the potential issues or problems that might come with tube feeding. So would you mind just saying that, Kathy and Joe, just saying a little bit about what those might be?
Joe, do you want me to, or are you going
Yeah,
to?
you start. That's fine. You can start, Kath. I'll chip in.
I think that there are, the first and foremost is there are risks to any kind of procedure, aren't there? There's risks in any surgical procedure. So that there's risks with general anaesthetic, and there's risks with infection when PEGs are inserted. And in our experience, and I know it's not Kira's not so much, it might be where they're inserted around the country, we've had dislodgement issues and PEGs coming out and requiring reinsertion. So there is, in the earlier days of a PEG insertion, which is stressful for the person and stressful for the families and stressful for the people that are looking after them. So there's that risk. And if you are considering a PEG, you need to discuss it with your surgical team or the doctor that's going to place it, because you need to be thinking about the types of movements that you might experience. Because if you've got quite a reflexive core movement where you're rocking backwards and forwards, that's going to be an issue that they're going to need to know about, because the PEGs can easily become dislodged in those early days if you've got that kind of movement. But Joe mentioned that at the beginning, it might have to be done under surgical, under general anaesthetic, in order to maintain that safety whilst the PEG is settling in. And the PEG settling in period can take up to about 3 weeks for the tract to form. So if there's a risk of moving around within that 3 weeks, and the tube can become dislodged within that time, but it needs a lot of monitoring in those early days. And infection into the PEG site is obviously another risk there. Feeding does take time. It can take, if you have 5 or more mini feeds per day or longer feeds, it can run over 8 to 12 hours. So it is time consuming sometimes. Some people have them overnight in the nursing home that we have. We would set them up at more productive times of the day, or less intrusive times of the day. But it is something that has you to get the fluid and food in. It doesn't stop you choking. It stops you choking on food that you're eating, but you can still aspirate your own saliva or any food. It won't diminish that risk of choking if you're going to combine the two. And it can still happen, as I say, even on saliva, you're still going to be experiencing some challenge to your throat. But we're always quite keen on maintaining a good cough. So there are other strategies that you can bring into place to minimise some of the risks of choking. But it doesn't, having a PEG that won't stop you choking if you are combining the two. Some people are irritated by the PEG being there. If we all know the nature of Huntington's disease is irritability and impulsiveness in some cases, and so having something there can be irritating, and they may try to tug and pull at it multiple times. And certainly in my experience, and in Joe's too, I think patients pulling the PEGs out was quite a challenge, because you have to get them back to hospital to be reinserted, or have a gastrostomy tube put in to reinsert, and then it might be pulled to get out again the next day. So that was something that we had to face, and had to think about why they were doing that, and what was the cause of that, and what we needed to do going forward from that. There's some of our patients felt that the social aspect of sitting up to the table and having a meal was lost when you had a peg, that you would just have, being assisted to be fed, and your feeds being set up away from the dining area, away from that social aspect, which is something that maybe some people like to continue to be involved in. And once it is in, it cannot be removed, and feeding cannot be stopped without conversation, without consultation, without agreement from everybody involved. And if you become unable to communicate your thoughts and feelings about that, then that decision is going to be made for you. And that is the biggest challenge that we face as nurses and care team looking after somebody who has a PEG. Unless we know what you want to happen, it's very difficult to stop using it and withdrawing it. Although Kira and I were talking earlier in the week, and you can respond to a change in condition. So correct me if I'm wrong, Kira, if they are becoming intolerant to the feeds, if they're getting a lot of diarrhea or a lot of regurgitation, you can tailor the feeds down and off and out if that is indicated. We can respond to the way the body is deteriorating itself. But you can't just say, oh, I think they've had enough now, we need to stop feeding them, because that's not going to be possible unless you've got the correct documentations in place. And I think we're going to come on to that a bit later on. And Jo, anything else you want to add to that?
I don't think so. I think you've pretty much covered it all, Kath. Yeah. Really.
Our biggest challenges in the nursing homes was that, wasn't it? Was them having had enough of it, and but we were unable to act on their behalf at that point because they weren't able to say what they wanted. And families had differing views. Maybe we could put it like that. If they'd had enough, but the families wanted them to continue, it's very difficult without clear guidance for a GP or a doctor to know how to act on their behalf.
Thanks very much, Kath. As you say, I think we're going to come back in a minute just to talk about about future planning and things, how that connects with this. So Kira, I think we're going to come to you and ask you really just to give an idea of what sort of life with a PEG tube kind of looks like, so people can sort of imagine what that actually looks like on a day-to-day basis.
Lovely, thank you, John. I suppose the first thing maybe to touch on is what kind of care is needed for the tube itself. So I suppose in the very early days when a tube is placed, it's kind of it needs to be done as cleanly as possible, all the care. So for the first, it varies a little bit across the country, but for the first kind of 10 to 14 days there or thereabouts, if you did decide to have a PEG tube, you would be sent home from hospital with kind of gauze and sterile water or saline salty water to clean it, and basically told to just clean it every day and not do very much else to it. But it's important that it's kept as cleanly as possible, because obviously it's a fresh wound and you don't want to get any infection, the same as any wound really. So it's kind of very clean care for the first 10 to 14 days, depending on where you are in the country. After that, the care changes really a little bit, and it's still important that you clean it every day. But when you're cleaning it after that initial 10 to 14 day period, then all you would be asked to do is clean it really like you would the rest of your body. So lots of people kind of just get into the shower in the morning and actually would clean it in the shower. You can use normal soap or shower gel or whatever on it. There's not an issue. You don't need any kind of fancy creams or potions or anything to clean the PEG site. But you would be asked obviously to clean it every day. If you weren't planning on having a shower or a bath or anything, then you would be asked just to kind of clean it with soap and water and make sure that you do that every day. Lots of people kind of ask when they've had the tube placed, when am I allowed to have a shower or a bath? You're in our area, and again, it might vary ever so slightly across the country. In our area, we say that you're allowed to have a shower after 48 hours after the placement is done. And that's absolutely fine because obviously the water's only running over it. With regard to a bath, a lot of people kind of imagine, and I've had lots of questions like that from clients, they think maybe they're going to get into the bath and if their tummy goes under the level of the water will just seep in the hole and they'll fill up on the inside. That doesn't happen at all. So you're able to have a bath once that kind of 10 to 14 day period has passed. That's our local information. You can then have a bath and again, just clean it in the bath the same as you would be doing cleaning the rest of yourself. And that only really takes 2 or 3 minutes a day. It's not a long process. If you're not, say if you've had a peg tube placed and you're not quite using it yet, if you're not using it for anything or you've decided to have a peg placed early so that it's there and ready for when you want it, the only things you have to do is, as I say, clean it once a day and flush it, again, maybe once to twice a day. Slightly different information might be across the country. And flushing it is just with like a needleless syringe. So you get a syringe that just screws directly into the type of tube that you would have. And all you would do is one syringe, which is kind of 50, 60 mils of water. All you would do is flush the tube once or twice a day, really just to keep the inside of the tube clean and make sure it kind of doesn't block at all. I suppose touching on the feeding side of things and what a possible feeding regimen would look like. As I said kind of earlier, it could be that you just need a very small amount of feed if you were going to continue to eat and drink as a kind of a reasonable bit. And generally what would happen if that was the case is the little Ensure or 40-sip drinks that you may have actually been having previously by mouth, those drinks can actually also be put through the peg. And quite often what would happen is it might be just maybe once or twice a day, we would ask you to put one of those little feeds through the peg, and that would be kind of topping up calorie and protein and vitamin wise. That would be topping up anything maybe that you weren't able to manage by mouth. And that's kind of the way it starts for a lot of people, is just maybe 1 or 2 small feeds a day. If things kind of progressed and eating was becoming a lot more difficult or the volume of food had decreased considerably, then obviously in consultation with your dietitian, you would have a chat about kind of how to increase it up. And I suppose to look at the other end of the scale, really, to tell you what if you weren't eating anything at all, what would feeding look like? And if you weren't eating anything at all, you kind of have 2 choices. You can either continue on with the Ensures and the 40-sip type drinks, but you would need to increase the volume of them. To give you an idea, but it is very much based on people's individual nutritional requirements, but to give you an idea, you would generally need a minimum of 5 of those little bottles a day. It doesn't tend very often to be much more than that, because if you had a higher calorie requirement than that, there are higher calorie bottles we can give you. But it would generally be at least 5 bottles a day. They need to be kind of spread over the course of the day. You can't give 5 bottles all at the one time, but spread. So think of them, I suppose, by 5 little mini meals spread over the course of the day, with kind of 2 or 3 hours in between them. So that's one way of doing it. If once you built up your feeding regimen, if you were on 5, or sometimes I have the odd person on 6 bottles a day, if they tolerate it really well, what you can do is you can try to give 2 bottles at a time. So to make it easy for the sums, if you were on 6 bottles a day, you could give 2 bottles at a time and do that 3 times a day. So it is very much like a kind of breakfast, lunch and dinner type meal feeds. The other alternative is, if you didn't want to do it by little mini meals, is we can get you a feeding pump. And I suppose the easiest way, if you've never seen it, I suppose the easiest way to describe the feeding pump is, we've all seen, if you go in to visit somebody in hospital, we've all seen a drip hanging up where people are having fluids run into their vein. It's kind of a very similar thing, only obviously the end of the tubing is connected on to your peg tube that's in your tummy. And we, instead of the fluids hanging up, we would have a big bag of feed hanging up. And the big bags of feed are very much just, they're like 5 bottles of Ensure or 40 sip all in one big bag. That's what they're like. And then what you can do is you can use a feeding pump to actually control the rate. So again, to give you an idea, what it might look like is that you would set up the feed at maybe kind of after you've gotten up and gotten washed and dressed in the morning. You'd set up the feed and then it would just run away in the background without you having to do anything to it at all until that bag was empty. But I suppose the thing to drive home on that side of things is you can't run in all that feed over 3 or 4 hours. Generally, you would be looking at a kind of minimum of an 8 hour feed. So kind of most of the day, the majority of the day would be spent kind of connected up to the feeding pump. From an eating point of view, once you've actually had a peg tube placed, if that's what you decided to do, obviously you would spend, or have to spend, if you wanted to, less time eating. So if you found obviously that meal times, like we said, are taking you a long time, you could just eat a kind of like a half a cereal bowl worth of your dinner, and it still only takes you 10 minutes rather than the big dinner plate worth of dinner that was taking you 3/4 of an hour. So it can be still, from a quality of life point of view, that you actually can still enjoy meals with your family, you can still enjoy social occasions, but there's not the same kind of pressure on to eat a certain amount of food. Or you can eat just a couple of teaspoons just purely for the taste, so that you don't have sometimes the difficulties associated with the swallowing, but you still get that kind of pleasure just from a spoonful of something. Or the option is you don't have to eat at all if it's become really difficult and a bit of a grind for you. You don't have to eat anything. We can give you all of the nutrition and all of the fluids that you need through a feeding tube. And then just again to touch on the fluid side of things, lots of people, by the time they've gotten to having a peg tube fitted, not everybody, but lots of people will be on maybe thickened fluids, where the speech and language therapist would have advised you to have thickening powder added to the drinks to make them a little bit thicker, because thicker fluids are easier to swallow than thinner fluids. And plenty of people get on really well with them. Plenty of people don't, and don't like them, and don't like their favorite cup of tea with added thickening powder into it. So again, from a quality of life point of view, if it means sometimes for people having less thickened fluids, they can see that as a real positive. And again, lastly, just from a medication point of view, it can be really difficult. And when you have, quite often it's not just a paracetamol for a headache. Sometimes people are on 10 or 12 tablets all in one go, and trying to get tablet after tablet down that are difficult to swallow, and you're trying to wash it down with fluid that's difficult to swallow sometimes as well. Being able to put medications through a tube can be a real upside for some people. And quite often we kind of think the big tablets are the problem, but actually the vast majority of people say to me it's the smaller tablets that are the problem, and it's the little tiny ones that you can hardly pick up that tend to kind of get lost in your mouth and are difficult to swallow. So we can get the medications changed to a liquid or a soluble version, and they can be put through the tube, which can take that pressure off having to swallow this volume kind of 2 or 3 or 4 times a day.
Thanks, Kira. I suppose the next thing I'm going to ask, and I suppose it's a question really to everyone, really, is about what the alternatives are. So if you're at the point where you know a tube might be suggested, but you don't want to have that. So what might the alternatives be in terms of sort of getting enough nutrition in? What sort of things might be suggested to someone?
I think, like Kira's already talked about, supplements. So increasing the amount of supplements is one option if you're able to tolerate them and swallow those.
From a supplement side of things, I suppose, again, just to say that the feeds that run in through a peg tube are only the same as those drinks that you can take by mouth. So if you are managing fluids and you're not managing solids, you can get a completely nutritionally adequate diet by drinking enough of the supplement drinks.
Yeah. Right. I think also that there comes a point where you're not worried so much about maintaining a massive amount of weight. If you've become, if your condition has deteriorated slowly along the trajectory, and you're not moving about so much, and you're being, you know, looked after at home, or, you know, in a chair, or you know, if things are deteriorated down, then having a peg isn't going to make, if you isn't going to adjust that, isn't going to change that, the way that the disease is progressing. And in other conditions, neurological conditions like dementia, for example, we wouldn't think about putting a peg tube in. This is about your recognition of your quality of life being affected at that point. So we've certainly, Joe and I, seen patients come in with good quality of life, able to walk about, able to enjoy things, and being, you know, being in company at meal times, but being frightened to eat. So the peg made a big difference to their quality of life. In the same instance, we've had patients that have come in who are quite further advanced in the disease process, not enjoying and managing a diet. Yes, coughing through their meals, and yes, it takes a bit of time, but they're still managing to get enough nutrition in to keep them well enough and healthy enough, and they're everything moving through properly. But putting a peg in at that point wouldn't make any difference to their quality of life, other than making their life longer, and that is often a question that we have to discuss with them and their families, that maybe a peg is a good thing now, but I'm not sure that it is, and we have to make those kind of discussions and decisions earlier in the disease process, really. But you know, from a continuing to help someone feed point of view, you need to get advice on the best posture to help someone eat, so that that choking risk is minimized. Because if someone's lying down in a chair, or they prefer to be lying down, trying to feed someone when they're lying down is really difficult and very challenging, and a big risk to choking. So you need to make sure they're sitting up properly, that you've got good bolsters behind them so they can cough against, that what you're putting in their mouths isn't too big for them to swallow safely, and that you're supporting them when they are coughing, because coughing is frightening, but coughing is good because it's clearing the blockages. When they're not coughing that we start to worry. We would listen to them coughing, and then if they stop coughing, we all jump up and go, well, what's going on now? So you can manage eating and nutrition in a normal deteriorating trajectory. I suppose, you know, that's the market that we worked with most, was when people were coming into the last few years of their life, and having a peg wouldn't have made a lot of difference at that point. Those that came in with a peg at the last few years of their life, it was more challenging then to make decisions, because they were then well hydrated, well nourished, and at a good healthy weight, but were still significantly deteriorated in their condition, and that is a challenge that is difficult to face at that point. But as I said, in some of the other conditions, we wouldn't think to put a peg in if they were significantly deteriorated. And I give the example of my father-in-law, who had dementia, and he would pouch his food. He wouldn't swallow it. He just hold it in his mouth. He could swallow, but he didn't. And so he would lose weight, and his teeth were rotting because he was doing it, and he was aspirating. But we wouldn't have thought to put it peg in, because it wouldn't have made any difference to his quality of life at that point. And so he deteriorated, and he lost weight, and he did aspirate in the end, and he did get pneumonia and die. But that in some respects is a normal disease progression of a complex neurological condition. And I think that the PEG argument is bigger. You know, the quality of life is enhanced without a question when life is of a good quality, but when life becomes under some kind of a change and there's more stresses, quality of life is then a challenge.
It is really important to have these discussions, and there are people out there, you know, dietitians, speech and language therapists, your local HDA advisor, really, that would be happy to have sort of conversations about that and give you all sort of the facts and things and information about it to help people make those decisions. And we have got some links at the end to help people as well. And it's really important that those sort of conversations are written down and that people know what your wishes are, and that it's shared with everybody who's involved in your care, so everybody knows about it. Anybody who's going to speak on your behalf needs to have power of attorney. So that's another good conversation to be having, about having power of attorneys set up and advanced directives as well, to have wishes written down. Kath, did you want to say anything about advanced directives?
Sure. An advanced decision to refuse treatment, it can be, you know, if you're saying, yes, I want a PEG, but I want it stopped when my quality of life is unrecognisable, you need to be clear about what that means. And everyone who around you who's going to help you needs to understand what that means too, because that's where there is the challenge with PEGs. PEGs are great and can transform your life. I don't want anyone to get the wrong impression about what we're trying to say here. The challenge that we face with PEG in the later stages of a normal disease progression, when someone has a long and deteriorating condition, the challenge with PEG is being able to stop using it. And a number of the issues that we've had, and I've spoken before at these events, as people have said, we couldn't get him the care that he wanted because he didn't want to go on like this. He didn't want this to continue. And I had an email that Ruth sent me a while ago where they put the PEG in, and then they just thought, you know, a kind doctor would understand when they were deteriorated enough to stop bleeding, and it didn't happen. And they went on for another sort of 7 years. And that's certainly what we have seen in our care, is where somebody who wouldn't have wanted to continue to live as disabled as they were couldn't change that progression because there was no information about their decision. Now, yes, as Joe said, you need to have a power of attorney who is going to speak on your behalf, and they have to agree with you as well, because your power of attorney can then suddenly say, oh no, I don't want them to go, and I want them to be on this planet as long as possible, which we all feel about the people that we love, but that might not be what you wanted, or that, you know, the person with HD wanted. And so that whoever you're going to have as power of attorney needs to understand how you feel, what you think, what life looks like, and what an intolerable life looks like for you, and make that change, and make sure that's written down clearly. Then an advanced decision to refuse treatment. You can say, when my quality of life looks like this, whatever it is, I'm not looking at you in the eye, I can't speak, I don't enjoy anything anymore. And then they can take that to the professionals and say, can we please sort of start to remove some of the nutrition and see where we go with that. But you can change your mind also with that advanced decision to refuse treatment. So once you've written it down, you can change your mind and make a choice if you can communicate capacity and you can communicate your choices well enough. And I know, that being said, the guys that we looked after who have not had PEGs and who have deteriorated and died have been able to say yes and no and make a choice fairly late into the day of their conditions. In fact, weeks before they died, they were still able to say yes and no, and I want it to be this way. So, you know, it doesn't automatically mean that not being able to communicate as verbally as you used to means that you can't communicate yes and no clearly and show capacity. So future planning and end of life planning and about care planning all mean the same thing, really. But end of life planning is the scary word I've plunked in the middle there. When people talk about that, they get a bit frazzled and go, I don't want to think about it, I don't want to talk about it, because you're thinking about the day of your death. That's what you're thinking about when you talk about end of life planning, is that moment when you're not going to be here and you're going to be leaving the people that you love. That's not what end of life planning is, because everyone dies in exactly the same way. So you know, end of life in Huntington's disease, end of life in motor neuron, end of life, it looks like the same thing at the end of their life. The process of running up to it is very different, and that's what we need to discuss, and that's what we need to know about, and that's what you need to think about. So don't shy away from it and talk about it, because it isn't going to bring it on. It's not going to make any difference if you talk about it today. It doesn't mean you're going to die tomorrow. It just means that we know what and how you would like your last few years of life to be. I in another job I have is I'm an end of life doula, which helps people plan and manage, and you know, and get them to the end of their life in the way that they want. And I started working with a woman 5 years ago, planning her end of life. She had a respiratory problem. It wasn't HD, and she died last week. And she died in the way that she wanted to go, in a hospice with her family around her. But it's taken 5 years for her to die. But she got me on board 5 years ago when she thought she was dying. So it can take a long time when you, from what you think and when you get there. But over the last 5 years, she's managed to get herself in a place where she was, you know, content and pain-free and ready to say goodbye in a positive way, which is what we all want.
I think it's, you know, a lot of people with Huntington's disease lose a lot of control over things in their life. And if you've been in control and planned your own, been involved in your own end of life plans, then at least, you know, you still have some control right through that stage as well, really. And hopefully everybody's going to respect those wishes and carry them through.
Exactly. And having those advanced directives in this instance about PEGs, but it can be about anything. But it's about thinking about what you don't want and how you don't want to be, and making sure that you're clear about that, really, and what you wish to avoid, which is, you know, pain and fear and it being in the right place with the right people around you. That's basically how we all want to go, I think, and making sure that everyone knows what that looks like. But that is the issue about PEGs. Going back to the subject, is they are great and they can change your life, but they also have some issues at the end there which can make it a bit.
For a second, yeah, as well, I suppose, just maybe to make the point, because we are obviously talking about peg feeding, is if somebody is actually planning a lasting power of attorney and actually filling in paperwork and so on, there is, in the paperwork, you do have to, one of the questions is, would you like your attorney, the person making decisions on your behalf if you're no longer able to make them, do you want your attorney to be able to make life-sustaining decisions? And you have to check option A is yes, I do want them to be allowed to do that, and option B is no, I don't want them to be allowed to do that. A PEG is considered by law in the context of a lasting power of attorney as a life-sustaining decision. So if you want somebody to be able to make a decision about kind of PEG placement and so on, if you were unable to do that yourself, you would have to make sure that option A is ticked, that you allow them to make life-sustaining decisions. So I just wanted to add that in. And I think just the last thing really I wanted to say was just, I suppose, for anybody maybe that is considering having the conversation, is I know definitely, I'll speak from my own point of view, from our local multidisciplinary team that supports people with HD, none of us have an agenda of and particularly I think people think, oh, the dietitian is going to want me to have a peg tube in. I have absolutely no opinion as to whether a peg tube is a good or a bad decision for any single person that I've come across. I think our job as health professionals is just to give people the information that they need in order to be able to make a good decision for themselves. And just the very last point is, if you do have that conversation, it doesn't mean that having the conversation means you're committing to having a peg being placed. Not at all. You can have the conversation and go, thanks very much for all the information, I've decided against it, and that is perfectly fine. And if you do that, your healthcare team won't suddenly desert you. So you can decide against a peg and your care team will be there, dietitians and all will be there exactly the same as they were beforehand.
And you can also decide against it and then a month later change your mind.
Exactly.
And vice versa.
Some of these things we've come across. So obviously, I think we're talking things through with that, you know, a relevant professional. So the most obvious people are probably a dietitian like Kira, or a speech and language therapist. Does anyone want to talk about the MNDA MyTube site? Kira, you're nodding.
Yeah,
You
I
okay?
can talk about that. I think the reason it seems a bit bizarre, obviously, because it's for a different condition, but it's such a good website. It's a really good and useful resource if you're looking for more information. The way it's very much video based. And the way it's kind of set out is there's sections about if you're thinking about having a peg, and there's a section about the fitting of the peg. There's a separate section about kind of living with a peg and what life with a peg looks like. And also there's a section for carers, so that for kind of family members or care staff, about kind of caring for somebody with a peg tube in. And you can basically watch as much or as little as you actually fancy watching in order to get more information. But there's also a section on there as well about what happens if you decide against having a peg. So the kind of an awful lot of the information is completely applicable to HD, and it's a really good resource.
Thanks. And Kathy, I think these are a couple of articles that you've
Yes, that I shared. So that the best interest one is it talks about I think Parkinson's as well as, but it uses Huntington's disease as an example case study. So I thought it was quite an interesting one to share, because I think within that study he does change his mind, and it doesn't all go to quite the plan. So that's an interesting, just for you to have a read through. And the effects of PEG in patients with Huntington's disease one is a new one from 2021, and it kind of goes through some of the the positive and negative effects of that, which is what we've been trying to share. So it's a very interesting article to have a read of, just to give you a bit more information of some of the studies that have been going on out there in the research world.
Great, thanks very much. And this kind of brings us to the end of what we had planned. So say thank you very much for coming along today, and hope you enjoy the rest of your day. So thank you very much.